right, thank you for those who have been able to join us. Apologies for the delay. My name is Jonathan Yoder. I'm with Axiom Healthcare Strategies. We are joined here today by several experts within the oncology field. Um, One of our core focuses here during today's discussion is to think about a little bit of the so what. Now that we are in the post-ASCO realm, how do we think about the interpretation of all the good data that was presented? I think as a think tank, we tend to try to challenge ourselves with these questions and ask those kind of critical, thought-provoking ideas around how do we leverage this data? How do we think about furthering clinical development? And what is important not only to the patient, but to the clinicians that we're joined here with today. I'm joined by my colleague, Sarah Yablonsky, as well as Dr. Kasi, Dr. Lisberg, and Dr. Moore. I'll now pass it off to Dr. Kazi to give his introduction.
Well, thanks for having me. My name is Pashtoon. I'm a GI oncologist. I'm the medical director for GI oncology here at City of Hope, Orange County. As I said, I treat and focus on patients with gastrointestinal cancers and do a lot of research on liquid biopsies, circulating tumor DNA, circulating tumor cells, and glad to be here.
Welcome. And Dr. Lisberg.
Yeah, my name is Aaron Lisberg. I'm a thoracic medical oncologist at UCLA, developing a lot of novel agents in the disease, and main focuses are ADCs and immunotherapy.
Welcome. And Dr. Moore.
Hi, Kathleen Moore. I'm the Deputy Director at the Stephenson Cancer Center in Oklahoma City. I'm a GYN oncologist and a phase 1 trialist, and my expertise has been predominantly around DNA damage agents and antibody drug conjugates, and a little bit on T-cell engagers and engineered T-cells, just starting in that area in GYN, but that's what I do.
Excellent. So for our attendees, feel free to drop any questions you might have into the Q&A function at I believe, the bottom of the screen. And to start things off, I think it'd be interesting to hear from each of your perspectives, thinking about what are some of those driving factors that you're starting to see, whether it be within the development of ADCs, and even as you just mentioned, Dr. Moore, with some of the bispecifics or even T-cell engagers starting to emerge within each of your tumors. And any one of you can feel free to jump in first if you have an initial perspective.
I can maybe start because I guess we were somewhat lucky where we had several plenaries from a gastrointestinal standpoint make it to the plenary session at ASCO. So, some people were saying with the number of presentations we had, it seemed like almost like a GI ASCO. So as many of you are aware and saw, I think a big overarching theme, which is being replicated across tumor types, is the early adaptation or just moving up the ladder for immunotherapy for checkpoint for a lot of tumor types. And while there's of course a lot of excitement about the novel drugs and new therapies, it's interesting that how the setting is also making a difference. Whether it's new adjuvant melanoma data versus the same checkpoint dose or two before. It's consistently, there's something about simplistically the mothership still in you with the host immune response, the new antigens, that the same immunotherapy, whether it's new adjuvant or perioperative, is better than just the adjuvant approach. And we saw the Matterhorn study, which is for the audience, inclusion of immunotherapy in the form of durvalumab as an PD-L1 to the backbone of chemotherapy. That's called FLOT, while FLOT has been adopted as the standard of care for stomach and esophageal cancer. The big question of inclusion of immunotherapy is something that previously there have been some mixed negative studies, but this was the first official positive study and made it to the plenary. And along the same theme, we had a different kind of immunotherapy, again, this time in colorectal cancer in the so-called ATOMIC study, which was the MSI high bucket of things. And to your comment, John, earlier, some of these advances are coming for everybody, like the Matterhorn for perioperative immunotherapy for anybody with resectable gastric or esophageal cancer, whereas some of them are for the subsets of subsets. And if there's one subset that's most conducive to checkpoint blockade, and Dr. Moore, of course, sees a lot of these in GYN, are the mismatch repair deficient, MSI high. And this is one of the first studies, if I'm not mistaken, that's looking at the inclusion of IO in the adjuvant setting, because despite all the favorable biology, a proportion of these patients do not get cured with chemo alone, almost a third. So the question of can we do immunotherapy, and of course neoadjuvant immunotherapy in the form of the niche study and some of our work and some of the work from the group in the Netherlands has kind of like set the bar very high with 100% disease-free survival of just one dose of ipi-nivo in the neoadjuvant setting. But a lot of these patients still go for surgery. So the question is, does adjuvant IO help? And it was at least 10% more people who were getting cured, with the inclusion of immunotherapy. So, I'll stop there because there's a lot to talk about. But I think just the overarching theme of just not just the immunotherapy for the right patient, but also the setting could make a huge impact in the proportion of people that we can cure. Of course, Aaron can comment more from thoracic and some of the other tumor types that are doing more neoadjuvant and perioperative, but I think we're coming to the party as well from GI oncology.
Yeah, I can dovetail on that. I think that was obviously a great summary. And I think we are seeing a lot of parallels across disease types as was introduced at the beginning of this town hall. So in the lung space, certainly there was exciting data in the neoadjuvant setting, really continuing to emphasize that, as was mentioned, getting these drugs to our patients early can increase survival. So chemotherapy plus nivolumab looked very good. There were also updates from the NeoCOAST-2 study, which is looking at introducing ADCs in that space, which can also potentially lead to a higher cure rate. So I think that's very exciting. In the lung cancer space, we had additional data suggesting that a novel biomarker in the TROP2 ADC context could be predictive also in the frontline setting when combining TROP2 ADC with immunotherapy plus or minus chemotherapy. So that's interesting. And we had some advances in small cell. That's an area that I think has really had a lot of attention in the last year or two, which is really exciting because it's an area that we certainly need better therapies. It's a very aggressive disease type. And I would say prior to a couple years ago when immunotherapy came into our frontline approach, we really didn't have a lot of advances. But now we have the possibility of using lurbinectedin in the maintenance setting, which we can discuss today, and potentially a new standard of care in our second line extensive stage small cell lung cancer with tarlatamab, really additional data suggesting that there is an overall survival benefit. So a lot of exciting developments at ASCO in the lung space, I think that really do move the needle forward and hopefully give better outcomes to our patients we can discuss today.
So in GYN, number one, we really do pay attention to what's happening in the rest of solid tumors. We pay attention a lot to lung and head and neck for cervix, of course, and colorectal for endometrial, especially as regards to DMMR and tumor mutation burden high. Or microsatellite high, pardon me. But for ovary, we've been a little bit, I think we've recognized that it's just a different disease. It's a copy number driven disease, and we've been a little bit on an island. We've tried to follow breast for a long time, and it's just a different disease. So I think for us at ASCO, there were some important things. There were maybe one thing that was practice changing. I think we'll talk about the Rosella study today. Although the OS was a little premature, it was the second, only the second study in the past decade to improve progression-free survival in platinum-resistant ovarian cancer. So that is quite an accomplishment, and we're excited about that. We had a little bit disappointing news. You're just to dovetail on the immunotherapy discussion, moving things up, moving them earlier for us has not helped. Now for pretty negative studies of moving immune checkpoint inhibitors with chemotherapy into follow in frontline ovarian cancer just does not help. And in some cases may harm our patients. And so I think we need to move on from that. 5,000 patients, I think we need to move on. But, there were, I think, a lot of things that were done, both in ovarian and endometrial and cervix that give us the hypotheses we need to start moving forward. We've been, for many, many decades, kind of locked into taxanes and platinums. That was sort of what we had. That's what we used. We just kept using the peg and hammer with those two things. And with immunotherapy in cervix cancer, we saw updated overall survival data from the what we call A18 in local regional disease, really confirming the overall survival benefit and likely cure benefit in patients with local regionally advanced cervix cancer. So that was very important for us to see. We continue to see some benefit with immunotherapy, even in biomarker negative populations in endometrial cancer, and we talked about some of that data at ASCO as well with DuoE. But I think for us, the kind of big lessons were all in developmental therapeutics in posters, where we're starting to move sort of targeted antibody drug conjugates. There's some emerging signals about bispecifics into our patient populations. And the big questions for us that I bet are going to overlap with my colleagues are, we have a panoply of these camptothecin payloads. What's the right one for my patient?
Yeah.
What's the biomarker? And we are following the TROP2 NMS story very closely because it's been a very difficult biomarker for us to suss out, just like other tumors. What's the right drug in the right patient at the right time, at what dose, and for how long? Like, we're really just beginning to figure that out in GYN, and it's such an important question to really get these drugs right. Because I actually do think, and I may be overly optimistic, I think all oncologists are optimistic, but you know, frontline ovary, we've cured a proportion with PARP, mainly BRCA, maybe a few who are homologous recombination deficient, but for the most part, patients still recur because the disease is so heterogeneous at the get-go. But you know, if you have a subset that's HER2 3+, if you have a subset that's cadherin 6 super high, or folate super high, and you bring in these sort of little atomic bombs of camptothecin payloads, can we wipe it out? You know, I'm interested to figure that out for our patients. We did not see that yet at ASCO. We've got some work to do.
And, you know, Dr. Moore, kind of building on the right drug and more on the immunotherapy story, that serendipitously is something that we've been watching closely in colorectal cancer. You know, two other things that I tell all my patients, and also is something that, you know, is crossing disciplines, is to your comment about the right drug. While the current checkpoint inhibitors may have not made the impact that we would like to see in some of these quote unquote cold cancers, not the DMMR, but most of our MSS patients are 96% of our metastatic colorectal cancer patients. So we're seeing for the first time some of these like next generation of CTLA-4 inhibitors showing activity that the older ones didn't. Some of these don't even like to be called the second generation because they're probably not the same drug, or they go by multi-immune activators, or whatever term you want to call them, like the next generation of CTLA-4 inhibitors. For the first time, you know, in MSS colorectal cancer with, again, it's in the bucket of the no liver mets. So again, an interesting biomarker, as long as you don't have liver metastases. There were 3 trials, you know, one was showing more readout with the botensilimab, balstilimab, bot-bal story with the MSS colorectal cancer, and there was more data on biomarker and posters and stuff. And they already had presented at GI ASCO, one of the oral presentation with Dr. Fakir showing that it was clearly superior than our salvage therapy options. And some of these patients have these prolonged durable control that are becoming, you know, these cures that we never talked about in MSS colorectal cancer. And along that story, you know, there were two other companies and their molecules. One of them, the so-called Vilastobart, was more of a coated CTLA-4, and another molecule by the name of ADG126, again, a different kind of FC-enhanced CTLA-4 inhibitors. And they're all similarly showing like a third of the time it's causing pretty good shrinkage. And some of these responses were very remarkable to see at ASCO. And I think some of these drugs, and if you look at their story, they're going beyond, you know, CRC, because it's checkpoint inhibition. It's not necessarily CRC specific. I think CRC just happens to be, we're lucky that happens to be the poster child that they want to focus on from a cold tumor type, but they're going into, for example, refractory lung or sarcomas or some other tumor types that, you know, we consider as the not so-called hot tumors, so to speak, with their activity. So I think it's an interesting time where, to your comment about the right drug, the right setting, I think it cannot be more appropriate for what is going on at ASCO right now.
And building off of that, I know you mentioned CTLA-4 and how it's kind of evolving. I know that there's also a PD-1 CTLA-4 bispecific. Any thoughts on that and kind of this movement that we're seeing towards these bispecifics that are pieces of MOAs that we know in kind of new combinations and iterations, and thoughts on that and where they might fall?
Maybe Aaron can mention, because I'm pretty sure there was it a PD-1 VEGF New England Journal paper that is showing clearly superior activity than PD-1 alone. I haven't seen, at least from an efficacy standpoint, things that are farther down, at least within GI, there might be, like Dr. Moore said, a lot of action happening in the posters. So there are, of course, those bispecifics in development. And I think it's exciting. It's not just PD-1, CTLA-4, they're combining it with other targets. But it'd be interesting to see if it, stands up to it's one thing when you have biological plausibility and significance, then it's one thing showing it in actual human beings.
Yeah, so I can certainly speak to that. So ivonescimab is a drug that has gotten a lot of attention in the lung cancer space and beyond. And certainly there's a lot of enthusiasm, excitement. Actually, on the eve of ASCO, there was a press release, and that's all we have from the data from the Harmony A trial at this time. But it was actually a little disappointing because at the interim time point, DOS endpoint was not met for superior survival. So this is essentially trying to duplicate what is already standard practice in China with the drug in patients with EGFR mutant advanced metastatic non-small cell lung cancer. Again, majority are going to be non-squamous histology, vast majority. And this drug in combination with platinum doublet chemotherapy, which is our standard approach for these EGFR mutant patients with sensitizing mutations after progression on TKI. The combination of platinum doublet chemotherapy is certainly the standard of care, and this drug, this bispecific VEGF PD-1 inhibitor in combination with platinum doublet appeared to be superior in the Chinese population when randomized against chemotherapy, and so is approved. Now, this Harmony A trial essentially was the next evolution, where essentially the patients that were enrolled in China were folded into the analysis set here, and there were additional patients that were enrolled to increase the ex-China and specifically the United States population that was enrolled. And so at this interim time point, we're still seeing a PFS benefit, certainly in favor of the addition of this bispecific, but the overall survival is not statistically significant, although certainly a trend in that direction. So we'll have to see how things play out, but certainly we're not anticipating a near-term standard of care approval for this agent in that setting. I think this kind of harkens back to what we've seen in the disease, and there's a lot of biological sense based on experiential knowledge with the development of immunotherapies and anti-angiogenesis agents in the lung cancer space, specifically in the EGFR mutant space. Now, this again is a population that, at current point and current time, in the United States, I guess outside of China, we don't really have a place for immunotherapy in these patients. There's time and time again, we saw a lack of benefit to immunotherapy, even when combined with chemotherapy in these EGFR mutant patients. Now, if we look back at like IMpower 150, which was the 4-drug approach looking at carbotaxol, Bev, and tezolizumab, there was a subset that did appear to perform better than we saw with chemo IO alone in the EGFR mutant population. So potentially that's what we could be seeing here. But I think that the excitement surrounding this bispecific molecule or approach, specifically in the EGFR population, is to give these patients the opportunity to achieve the tail of the curve. And that's why I think the OS endpoint is so critical in these patients, and it will take time to see how this data matures and see if an OS benefit is in fact seen. But I think that it's obviously EGFR mutant disease is an area that we've had a lot of progress. We can certainly talk about some other developments there in terms of the ADC plans, which I think has been also very exciting in that space. But those patients, unfortunately, really don't have a viable immunotherapy path forward. So maybe this bispecific approach, again, combining two things that have been shown as individual components to potentially have a signal in favor of benefit in the EGFR population, specifically anti-angiogenesis with the immunotherapy, increasing the precision potentially of delivery of this antibody and the mechanism of action. But we will see how that plays out. I would say, the overall takeaway, unfortunately, from this ASCO press release or pre-ASCO press release was disappointment and the lack of ability for us to be, demonstrating overall survival benefit and potentially using this in our patients in the near term. But we'll see how it, I don't think the story is over. I think we'll see how it plays out over time.
Yeah, interesting to hear your perspectives, Dr. Lisberg, around, right? There are other VEGF PD-1, PD-L1s being developed. Do we think that, or do you kind of view them of maybe having a greater or different role rather in other areas within in thoracic oncology?
Yeah, I mean, I think that's an open question, right? So, there's been data that's emerged in the squamous disease, and there's data that's emerged across the spectrum of non-small cell lung cancer. And I think we'll have to see how the story plays out. Again, when we think about the developments in the bispecifics, as was discussed earlier, combining CTLA-4 potentially with PD-1, or combining anti-angiogenesis with PD-1, or even with the ADCs, as was mentioned earlier, delivering a strong DNA damaging agent directly to tumors. In some ways, we're kind of I don't think we're regressing anyway, but we're kind of falling back on the foundational pillars of oncology therapy in solid tumors: anti-angiogenesis, PD-1 inhibitors, and DNA damaging agents. I think that moving back in that direction, then figuring out more precise and more effective ways to deliver these known to be effective mechanisms of actions to our tumors is a potential path forward. I think that after, especially in the lung cancer space and even beyond, after the sea change that occurred with anti-PD therapy almost 10 years ago, there was a lot of interest in looking at novel combinations in terms of immunotherapy, looking at different checkpoints, LAG-3, TIM-3, all these different approaches, and a lot of them, have failed over time. And I think that just speaks to the complexity. And I think it's somewhat interesting that we're going back to kind of mechanisms of actions we know that are working, and just finding wider ways to deliver. So I do think over time that will pay dividends and will improve the outcomes in our patients.
Yeah. And Dr. Moore, curious to hear your thoughts. I believe there is some early stage development for these VEGF PD-1s or even other bispecifics within GYN.
Yeah.
Curious to hear any initial perspectives you might have.
Yeah, I think it's early days for us. We're, of course, I think probably most right now excited about the CTLA-4 PD-1 bispecifics. There actually is a phase 3 with volrustomig in cervix cancer that my partner and friend Leslie Randall is leading, trying to sort of optimize even beyond PD-1 or PD-L1 alone with chemo RT and to follow in a kind of high-risk local regional advanced population. And so that particular agent is of interest to us because they're interested in developing it in GYN. But there are others. BioNTech has one that we're interested in as well. And there's several companies that are kind of working in that space of CTLA-4 PD-1 or VEGF PD-1. And that makes a lot of sense, to us, first of all, for cervix cancer, potentially for endometrial, even deficient mismatch repair, where kind of like I say this in BRCA ovary, we're not, even though we've done great, and the incorporation of either dostarlimab or pembrolizumab with chemo and to follow in an advanced or recurrent DMMR tumor, those tumors, it's not like BRCA where they do better anyway. They do just as badly as not DMMR, and outcomes are unfortunately very poor. These are terminal diseases, and with immune checkpoint inhibitors, we may be curing some of these patients, if not just long-term disease-free survival, which in my lifetime is sort of one of the miracles of science. Like, to see that when I started treating patients now 2 decades ago, the likelihood of someone being alive 2 years with advanced recurrent endometrial cancer was 30%. Now, when understanding the biomarkers, we're curing some of those patients, but 20 to 30% of them progress within 12 months on immune checkpoint inhibitor. And then they kind of do the same as everyone else. So kind of why is that? And if you could identify who they are, and it's not epigenetic versus Lynch-like, we've looked at that. I thought it was going to be that easy, but it's not, clearly not. If you could figure out who needs more, would these, then do we look like Niche 2? If we bring in kind of a CTLA-4 PD-1 population, or would that look better in non-DMMR? We kind of have to see. So we're interested in that space there. We're very interested in VEGF immune checkpoint inhibitor combinations, especially with bispecifics, again, to augment outcomes and disease control in tumors that are not going to be right now cured with immune checkpoint inhibitor alone. So those are kind of our leading agents, but there are a number of, there's kind of bispecifics, and then you have your T-cell engagers. So we are interested in, there's a MUC16 CD3, there's a PRAME CD3 with HLA link. And we'll have to see how we use those drugs. I think either it may not work, But if it does work, it may be that we're just not quite at the place yet of understanding how to position them. They're not going to shrink tumors. You know, we're so tied to response rate, myself included, I'm throwing stones at me. But we're like, oh, the response rate with these antibody-drug conjugates, 50%, 50%. So we want to put all of our patients on those in the platinum-resistant space. And now we're trying to move them all up into maintenance. And I don't know if that, and I'm leading one of those studies. So I mean, again, throwing stones at my own glass house. And I hope that's a good idea. But it might be that these bispecifics, if you can get them to a point where we're not having to do them weekly, and some of them are every 21 days, if I induce a response and then I just hold it with something really relatively non-toxic, maybe a better approach for sequencing. And so I think there's a lot of interest in the bispecifics. They're not shrinking tumors as monotherapy, but they are clearly doing something if you look at the spider plots. And so do we believe there's a place for them? And where would that be is something that I don't think we've really figured out yet. But the other thing I'll just say, and we don't have enough time to talk about, is that specifically in ovary cancer, we've been locked into these definitions of platinum sensitive and platinum resistant for decades. And they're derived from an era where all we had was platinum, eventually a taxane, and an anthracycline, you know, and topotecan. Like that's what we had. And so we had these definitions, and the regulatory agencies still hold them to it, but they don't serve us anymore at all. You know, if you're platinum sensitive, but your tumor progressed on a PARP, what does that mean? If you're platinum resistant, but you responded to the last platinum 5.2 months ago, what does that mean? So we're really starting to push our understanding of the biology so we can figure out what to do with these medications that are showing signs of efficacy and get them into the right settings to really show their efficacy and sequence them appropriately. And that's going to be exciting, but also hard for us because we're not breast, you know, we don't have just this massive number of patients. And so we have to be very thoughtful about the studies. Not that you're not thoughtful, I don't mean that, but we have to be very thoughtful about the studies that we design so that we try to make them make an impact. And so if we start sort of making all these little niches, it gets harder. But the bispecifics may really require us to think outside of our current boxes and where we fit them and who gets them and for how long. I don't think is going to look like the way we currently design clinical trials if we want them to be successful. So a longer answer than you probably wanted, but I'm interested in bispecifics. We're, you'll be surprised, my lung colleague, we were really interested in tarlatamab because we take care of neuroendocrine tumors. I have 2 patients with neuroendocrine. I saw one of them today. And I'm putting her on a DLL3 CD47 clinical trial, but I also have tarlatamab in my back pocket. I'm so grateful to the lung community for developing that because we can get it off label. These bispecifics really work in the right setting. It's just who is that? And then get them the right drug. And so this is really a place where Gyn is paying attention to what's happening, and then trying to figure out how we best design the trials to prove these drugs will work in our patients.
Yeah.
Yeah.
Are you seeing, Dr. Moore, kind of an increased need for study around biomarker development? I think as one of the core themes I'm hearing across each of you is that, who is the right patient for the right therapy? Are there techniques or maybe whether it be novel biomarkers or new strategies that you and your colleagues are considering when trying to determine which therapies should I be selecting for my patients?
Well, we need to be. I'm not going to say we're not trying. There's just so much still to do. The ADCs are really, I think, going to push this effort because there's differences, so I led development of mirvetuximab. I'm very proud of that. Mirvetuximab is an antibody-drug conjugate targeting folate receptor alpha with a DM4 payload. The efficacy of mirvetuximab is very tied to the level of folate receptor alpha. there is efficacy when it's not high, but it's not as good. And I think that's true of a lot of microtubule toxins, whereas the newer ADCs with these camptothecin payloads seem to work more broadly. And I think we saw that in breast with TDM1 and TDXD and everything else. So that's not surprising. But now we're, in a space where we have camptothecin, we have a bunch of like 9 camptothecin payload folate, that however many trope, we've got a couple cadherin 6, we have forgetting one, well, of course HER2 from Destiny Pan Tumor, and then we have one other microtubule toxin, well, 2 B7H4 and a Claudin 6. So the microtubule toxins are over here, and we're figuring out those biomarkers because they don't necessarily overlap, folate and Claudin 6. So that might work out pretty well, and the patient will get one of those 2. But then you have your camptothecin payloads, and the response rates are all about 50%-ish in these 40 patient cohorts. So that's where we are right now in GYN, counting a lot of chickens out of these 40 patient egg baskets. And 50% is really good for us. In the platinum resistant setting, our benchmark is weekly paclitaxel at 30%, everything else about 10%. And if I don't have anything else, that's fine. Okay, I have this. But if I have multiple of these camptothecin payloads and a high cadherin 6 has a 70% response rate, I'm totally making this up, and a low has 30%, but a medium TROP2 with SASE TMT has a 50%, then I got to know those different levels, because I don't know that I can give more than one camptothecin payload yet in ovary. We don't even know if we can do that in breast, and they're ahead of us. So really understanding the predictive value of the biomarkers is going to be really important to picking the right drug, especially as they're already racing to platinum sensitive maintenance and frontline. They're racing for this space, which again is fine to advance things, but we really need to make sure that if I'm going to use a camptothecin ADC in the frontline as maintenance, A, I want to make sure it doesn't harm her down the road, but B, what's the best one for her? And does the biomarker matter? Because the other big question is, we're basing this all on immunohistochemistry from a biopsy. And that's just, that's a dinosaur technique, really, when we think about all the new things that we can do to really characterize the global status of a patient's biomarker. So I think we're going to have drugs before we have the right biomarkers for them.
Yeah.
And then we're going to be figuring it out on the back end, which, on one hand, I'm glad we'll have drugs available because patients desperately need this. And ultimately, that's why we're all here. But on the other hand, I think there's going to be some cost to some patients not getting the right drug for them because we're not figuring this out up front. So I really have this tension in drug development because it's what I do. And I want to get things available for patients. But I also feel like we're going real fast sometimes.
Yeah, it's hard to keep up sometimes. Dr. Kazi, kind of curious some of your perspectives, right? I think obviously we know with the HER2 assets, it's almost pan tumor. Whether it be how HER2 is unfolding or even some of the recent development with the Claudin 18.2s, how that's kind of looking within gastric cancer.
Yeah, I think, well, as Dr. Moore mentioned, it's now you have an agnostic approval for an ADC. There's still something to be said about the tissue specificity. And again, the agnostic approval is for the true HER2 3+, and when you start getting into the 2+ FISH positive, which is still positive for, and now we also at ASCO this year had second line data published simultaneously in New England Journal for gastric patients who can benefit from the ADC earlier on, even though the approval was or did allow for second line or beyond. This was truly the first second line study to show that beyond trastuzumab. But there are parallels where it helps other tumor types, but also when you start getting into the HER2 low and some of the stuff that's going on with, it's hard to keep up with the breast space with how low the drug is still working despite minimal or no expression. So I think while there's going to be the agnostic potential of things, especially when the high expression comes into play and it actually helps other tumor types. And, I focus on a lot of biliary tract cancers and cholangio and some of these orphan child cancers. They often need some of these agnostic approvals truly if they have the expression. But there's something to be said about, as Dr. Moore mentioned too, like, the right patient, and even within tissue type, there's going to be some more biomarker work for each tumor type. To your other comment about Claudin, that's the newest marker that we have, at least in gastric and in the proportion of esophageal adenocarcinomas. I think bispecifics, while everybody's been talking about bispecifics where it's, T cell or CD3 based and other stuff, there are some bispecifics where both the targets are the tumor marker like HER2. So we now have a bispecific that's the zanidatamab that is actually for cholangiocarcinoma, biliary tract cancer, gallbladder cancer approved. And it's good to have tumor type approvals besides the regular common tumor types. And, that is hitting both different aspects of HER2 and potentially can overcome resistance mechanisms that the traditional antibody may not come. So I think it's exciting, as Dr. Moore mentioned. There's a lot of things happening in the space of each tumor type and a lot of drugs and looking for the right biomarker. But I think you can't take the disease context out of the equation as well. There's something about each tumor type responding differently to any of these new drugs that we're talking about, whether it's ADC or bispecific. But I think the HER2 has really set an example, especially with some of the ADCs. The responses we're seeing that are also long-term durable, the proportion of patients keep increasing, especially the ones who are the true HER2 IHC3 plus patients. Yeah.
And I think this has been brought up before, but thinking about TROP2, it's kind of been a little hit or miss in terms of what are the right cutoffs and what does testing look like. I know that there's the new QCS method looking at the tissue samples. I think it was specifically looking at Tropion-Lung01 that was used. Any thoughts on TROP2 cutoffs and how that's being assessed and how that might change how TROP2 is used across the board and across the tumor types?
Yeah, so I can start on that point. So having been very involved in the Dato-DXd development story, it's been very interesting. I think it harkens back to a lot of the comments that were just made. We look at our our early publications on the phase 1 trial, looking at Dato, trying to test the hypothesis that we would anticipate would be true, which is that higher membrane scoring would correlate with response. And if you look back several years ago, we clearly showed that that was not the case. So that really required us to take a deeper look and try to identify different mechanisms by which biomarkers could be developed in the space. And so, yeah, last fall at World Lung, the plenary presented the TROP2 NMR score. And so essentially looking at an AI biomarker and essentially leveraging the ability to evaluate many cells and not simply looking at the membrane expression of TROP2, but actually looking at a ratio that incorporates the cytoplasmic expression. Interesting, again, in terms of the biology, to think about these biopsies that were assessed on the Tropion-Lung01 study, and then actually we have some data that was presented at ASCO looking at frontline data we can talk about as well. But these biopsies were baseline biopsies in our patients, prior to any introduction of the ADC. But the hypothesis and the understanding is biologically that TROP2 is trafficked from the membrane to the nucleus and back from the nucleus to the membrane. So if we take a snapshot in time at these baseline tumor samples, and essentially this biomarker is identifying the fact that if there's an increased proportion of the cytoplasmic expression, that there may be ongoing trafficking of the TROP2 protein, either, again, from the membrane to the nucleus or the nucleus to the membrane. And then when you introduce an ADC that then targets that protein, you're going to have increased efficacy. And that is what we saw specifically refined in the non-squamous, non-AGA population. I'll also make a comment from that study. The Dato story has been very interesting in lung and now has landed us potentially in the EGFR mutant space. But when we looked at the high-level data from Tropion-Lung01, we certainly identified a histologic breakdown where the non-squamous patients did much better and the squamous patients did not. And when we look at the prevalence of the biomarker from that initial presentation, we actually see in that table a clear, it's a reflection of what we've seen clinically, not proving causation in any way, but it's really suggestive. So the patients with the highest NMR scores are those patients with non-squamous AGA, which is the patient population, again, the EGFR population where the submission currently lies with the FDA, and the patient population with the lowest biomarker positivity or squamous population. So very interesting to see how this plays out, but certainly appears to be a promising biomarker for selection of this drug. And then the Tropion-Lung02 study was presented at ASCO just a couple weeks ago, and it was the first time we saw how this biomarker biomarker may perform in the setting of combinations. So combinations of data with pembro plus or minus chemotherapy, and in the overall patient population, it again appears that patients that were biomarker positive, again, having higher proportion of the cytoplasmic expression of TRO2 at baseline prior to introduction of the drug, are doing better both in the doublet setting, so Dato plus pembro, and the triplet setting, so Dato, pembro, and chemo. The numbers in that presentation are very small, so we'll have to see how this plays out, but we know there are a number of frontline trials that are ongoing and potentially will be reading out maybe in the next 6 months to a year. We have the frontline TL07 and TL08 studies that are stratified PD-L1. We know that PD-L1 high is a distinct disease type in non-small cell lung cancer. And we also have the AVANZAR study that's evaluating patients in combination with chemotherapy and was prospectively developed to incorporate this biomarker. So we're really going to see in the AVANZAR study how this biomarker may predict prospectively with patients that were enrolled after the development of the biomarker. And the TL07, TL08, it's going to be a secondary or exploratory endpoint. But I think it's very interesting to see how this all develops over time. And I think it speaks to the tip of the iceberg, I think, as many of the other doctors have spoken about today, that using these IHC techniques now involving AI to allow us to multiplex or look at many cells is great. But I think there's probably a lot more that we can be learning over time. And I agree with the sentiment from Dr. Moore that we're probably going to get these drugs before we know exactly how they're working. We haven't even answered the question whether sequencing of patients with topo-1 payload ADCs makes any sense, right? We would, again, hypothesize that once you become resistant to an ADC with DNA damaging agent payload, you probably would be resistant, but there is the possibility of other resistance mechanisms, including downregulation of the target and continued sensitivity to the payload, in which case continuation of an ADC with a different target and a similar class of payload may make sense. I'll just make the last comment on this setting. We did also have some other disappointing news in the lung space. We were excited about HER3-DXd or patritumab deruxtecan, which is a HER3 targeting ADC, very similar in design to Dato-DXd, but the HERTHENA-Lung02 data was presented at ASCO and it showed a very marginal PFS benefit, although statistically significant, but no OS benefit. So in the EGFR mutant population, we were anticipating the potential to be using this drug in the near term. Based on those findings, the submission to the FDA was withdrawn. So we'll have to see how that plays out. But a lot happening, both positive and negative. But I think it again speaks to the excitement surrounding these agents, the promise, but also to the reality that patient selections can be critical.
It's a great point. And I think you've touched on a lot of the main topics at ASCO, but from your perspective, what are the main takeaways relevant to lung in terms of what the big news was coming out of ASCO?
Yeah, so we talked about the two disappointments, but let's make it more positive. And we've hit on tarlatamab quickly, but I think that probably was one of the most exciting developments to me. We have the ability, the accelerated approval and the ability to use tarlatamab as a second-line therapy in our extensive stage small cell lung cancer patients. But the overall survival benefit, I think, was meaningful, statistically significant. And, our options 1 to 2 years ago in the second line setting for small cell lung cancer, you look at NCCN and you see 10 things listed and really no clear prioritization. I think that suggests that we don't have great options. Now, I think that tarlatamab is logistically challenging in some ways, but I think that those logistical barriers will come down. I think that a lot of centers are becoming more familiar with the administration, the ability to potentially move it to an outpatient setting, and the experience with other therapies across tumor types that have cytokine release syndrome. And I think the safety data that came out at ASCO, I think looked promising and very reasonable at this point. So I think that if I had to say the one thing that I think changed I think increased the enthusiasm and essentially kind of fortified the therapy, as I think would be our standard second line approach for our patients with extensive stage small cell. I think that was very exciting for me.
Yeah. Do you think there's a role for more DLL3s or even kind of the use of Tarla in earlier stages of setting in the future?
Yeah, I think that's an open question. Obviously, there are ADCs in the space as well, and we'll see. But yes, I think the answer is yes. I think obviously there are a number of ongoing studies looking at Tarla on the front line in both maintenance setting and other approaches. And I think that it makes a lot of sense, again, until the introduction of immunotherapy to our extensive, say, small cell patients, and more recently with our limited stage small cell patients, we really didn't have much. And it's still an extremely aggressive disease. The vast majority of patients progress very quickly. But, as we've been able to start giving immunotherapy to our patients over the past several years, we do have those patients, and they're not total unicorns where they have real durability of benefit on their maintenance immunotherapy. And I think Tarla provides the same potential promise with the ability to really give some patients an extended duration of benefit with minimal toxicity, which I think is a paradigm in an extensive stage small cell that was really unthinkable prior to the introduction of these therapies. So I think that as I said, as centers and individual providers become more comfortable administering this therapy, and the access becomes more pervasive, I think the possibility and excitement of introducing it to earlier line therapies, depending obviously how the data plays out, and the ability
Right.
to have that subset of patients that can have durable benefit, I think is very exciting.
Excellent. Dr. Kazi, kind of curious to hear from your perspective. Obviously, you mentioned Matterhorn at the start, but what were your kind of main takeaways within the gastric space coming out of ASCO?
Yeah, no, for sure. I also wanted to kind of mention, as some of these novel therapies are, and I think there's a question in the chat box as well about tolerability of some of these things. Again, everything has side effects, but of course, some of these novel therapies, they don't have necessarily overlapping side effects, let's say with chemotherapy. So one of the, practice changing, practice informing, which is one of the most aggressive subset of colorectal cancer patients are patients with BRAF V600E mutation, which again, has parallels across different tumor types, including lung and other tumor types. And we had, doubling of overall survival. You don't see that often. There was a parallel New England Journal publication, median OS going from 15 months to 30 months by moving up the best therapy first, but then also adding it to chemotherapy. So this was, the breakwater study where they combined RAF and EGFR blockade to FOLFOX. And again, is also another great example of where BRAF inhibition works agnostically across tumor types, but for colorectal cancer patients, you need the EGFR anti-EGFR blockade as well. Otherwise, these drugs do not work at all for patients with colorectal cancer. So I think that was, practice changing for us. And we already kind of touched upon the immunotherapy moving up the ladder in the perioperative space. And also, I'm still very excited about all the newer immunotherapy agents. As Dr. Lisberg mentioned, some of the, Asian studies, it's not an uncommon theme where it's not the same set of patients. Some of them haven't replicated the same results in the United States. However, I think that doesn't mean that, progress needs to stop there. I think there's a lot of targets. You mentioned gastric, we talked about Claudin 18.2, but again, as I've understood the marker, my understanding is the IHC currently a companion diagnostic is not even necessarily checking the exact target that the drug is checking for. So you can imagine how crude we are with our current approved, drug for Claudin 18.2, and so I think there's, and then my understanding is also to your comment about ADCs and some of these drugs, as you have the right marker, you may not need that level of expression, and it may even work for cutoffs which are lower than that. So we have many bispecifics and trials at City of Hope that are, for example, enrolling patients at lower expression for Claudin 18.2, for example, or going beyond to biliary tract cancer or pancreas cancer, because it's not necessarily gastric cancer where you see Claudin 18.2 expression. But the fact that they don't have the same level of toxicity, there are multiple tumor types where, adding it to the chemotherapy backbone or adding it to the IO partner, I think there's a lot of, new targets that are paving the way. We didn't talk about FGFR2, but it's just a matter of time before that phase 3 reports out. The phase 2 was very promising in terms of, and again, you see parallels of higher FGFR2 expression and the responses in gastric. So we are looking at not just MMR, just looking at a gastric cancer patient today, for example. I saw a young guy last week. I haven't started anything because in a good way, I don't know if my partner for a systemic backbone of chemotherapy, should that be an anti-PD-1? Should that be a anti-Claudin 18.2 drug? Should that be somebody that I enroll for an FGFR trial? Should I just do immunotherapy alone if it's truly MSI high, which is not, again, a small number? 8 to 10% of gastric cancers have mismatch repair deficiency. So while there are advances that are happening across tumor types and across agnostically as well, I think there is also a lot of subsets of subsets that are driving a lot of advances that are, exciting overall.
Excellent. And Dr. Moore, obviously you'd mentioned the Rosalia study at the start, right? And we've talked Rosella, sorry,
Rosella,
study
yeah.
at the start, but curious to hear from your perspective about ASCO.
So, I mean, I had a great ASCO. I'd see a lot of things that were talked about. It's just fun to be in the room when big science is presented. For GYNU, I think it was just mostly a learning ASCO for us. We had, I'll talk about Rosella in a second, but we're just a little bit behind, like ctDNA, like what are we doing with that? There were several presentations from big phase 3s where they collected Streck tubes as an exploratory endpoint and were presenting findings, which is really the first big data we've seen on whether or not our tumors even shed ctDNA and, you know, for local regionally advanced cervix, for advanced endometrial, and what it means. You know, I think we could have all guessed it was prognostic, but can it help us to identify tumors that are high risk? And then can we design the same sites of studies that have been done, for example, in rectal cancer to sort of triage escalation and de-escalation of therapies based on that is kind of the next step for us. So this was, while not practice changing, and I don't think people should go out and start sending these expensive tests off study, it was our first glimpse at the ability to detect what the clearance rates are and how this correlates with prognosis in some of our populations that I think will inform our work moving forward. So those were important pieces of information, although not yet practice changing. We did present the first study, which in full disclosure, I'm the US PI for, so I'm mentioning it, but it was a giant study, over 1,000 patients. The last one to read out, frontline ovarian cancer with PARP plus immunotherapy versus PARP alone, and was statistically positive, but not clinically practice changing, and for progression-free survival and no OS benefit. And so I think another either uninterpretable or negative study in that space that I think really just tells us ovary in general is not one where immune checkpoint inhibitors are going to be transformational, and that's okay. We just need to move on. So I think practice changing, because man, a lot of people just try to add that, you know, up front, just throw the kitchen sink at things. And I personally just think, and I led the study, so I can say this, I just think that's not a good idea for patients based on side effects and cost. In platinum resistant, as I mentioned earlier, we haven't had a win in platinum resistant ovarian cancer since what's called the Aurelia trial was published in 2012. And that was chemotherapy plus bevacizumab versus bevacizumab alone. Progression-free survival had a hazard ratio of like 0.4 something. So it was really positive, but interestingly, no OS on that study, but it became the standard of care and remains kind of the benchmark for platinum resistant ovarian cancer. We've done so many studies in this space over the last decade, all of them negative, until Mirasol with mirvetuximab and folate receptor alpha high, so subset, biomarker selected, PFS and OS. So that was our first win in a long time. And I led that study, so I'm biased there too. But I will say this, I'm very proud of it, and our patients need new medications and they're accessing it. But on the other hand, mirvetuximab, I actually put the first human being on mirvetuximab in 2012. So it's even though it's just approved, it's a very old drug, and there's new generation of antibody drug conjugates coming in. And so I think we'll have to see kind of what happens in the future. But Rosella was presented this year and will be the second positive for PFS study. And this is interesting because it takes our best chemo backbone, which is a taxane. Everything else works not well. Taxanes work, and that's important to say. And anything we've done taxane plus something versus a taxane hasn't worked, because it's just hard to beat a 30% response rate and a PFS of about 5.5 months. And they went up with Abraxane because they had relacorilant is a glucocorticoid receptor inhibitor. So they didn't want the competing effect of of steroids, which we have to use as pre-treatment for paclitaxel, of course. They went with Abraxane, which has the exact same efficacy as Taxol, plus relacorilant versus Abraxane. And Abraxane actually absolutely performed as we would expect. 30% response rate, 5.5 months. It was not an underperforming control arm. I think that's important to note. And they beat it. It's modest. It's a hazard ratio of 0.7. It's just a little bit worse than what we did with Mirasol, but not that far off. We were 0.67, 0.65 with Mirasol. They were 0.7. So it's a modest, both are modest, let's just say.
Yeah.
PFS. Their OS was not, at the interim, was not statistically significant, but it was pretty far apart. So I think we're all kind of waiting to see, and I don't know how that makes sense, but I'm not gonna question it. If we improve OS, I'm down with that. But we're all waiting to see the final readout of that. And based on the paper, which was published simultaneously, and the presentation, the toxicity profile is, I think I would like to see the quality of life, which was not presented. So we didn't really get the patient's voice from this at all, but at least what they presented didn't have a lot of discontinuations, or things that you would think maybe signaled a poorly tolerated medication. So I do think it's another win. Whether or not it becomes FDA approved, I think will depend on the OS maturity. But gives us two active therapies, because it's not either or MIRV and weekly or Abraxane relacorilant, both for patients that are FR alpha high. For those 67 or 60% who are not FR alpha high, it's that, and all the patients were, also importantly, all the patients had prior bevacizumab. So this was actually a pretty high risk, early platinum resistance, all prior bevacizumab, and they won there. So I think that's worth noting. It's a modest improvement, but you keep cobbling things together for patients that have differentiated toxicity profiles, prolongs PFS, and you cobble together, OS until we figure out how to cure this thing. So I think that was probably the one presentation that was potentially practice changing, assuming we get access to the medication, and then the question is it just a combination for Abraxane, or is it just something that by blocking the cortisol signaling, which people have been talking about forever, that this was a negative prognostic biology, can you just add it to anything, and make it work better? I think that's sort of the next wonder with this. So I think we may just be seeing the beginning of the relacorilant story with this. And so I think just stay tuned.
Yeah. Excellent. Well, I know we're kind of coming up on the hour here. So an initial thank you again to each of you for joining. I'd be curious, quick 30-second of what are you looking forward to most to come within each of your respective fields? And why don't we start off with Dr. Lisberg?
Sure. Yeah, I think that building on a lot of the discussion that we've had today, I think that the ADC space, the immunotherapy space, potentially the bispecific T-cell engagers, and I think in addition, the ability to kind of continue to piece out the pie in terms of patients with actionable genomic alterations, what that means. We continue to see patients who are young non-smokers that don't have a targetable alteration. And when I speak with them, I always say, in a couple of years, we may know what that is. And I think that continues to be a way we've made a lot of progress in the disease. I don't think it's a topic we've discussed at length today because there weren't any kind of groundbreaking developments at ASCO in this space. But I think that continuing to be able to molecularly identify liabilities in our tumors and pairing our therapies in that way as well, I think will be very exciting moving forward.
Excellent. Thank you, Dr. Lisberg. Dr. Kazi. I
think I'm still very optimistic and overall excited about all the immunotherapy-based advances. I think maybe the commercially available current PD-1, PD-L1 may not be the only answer, but even those are showing promise, as you saw in 2 plenaries at ASCO, that moving it up in the earlier setting. And then for the ones who are in the refractory metastatic setting, I think the next generation of immunotherapies are bringing the promise of, as Dr. Moore mentioned, these prolonged, durable controls that we hesitantly are now calling the word cures because they're off of therapies and on nothing. So again, it's something tangibly that I'm seeing in the clinic every week that excites me the most.
Excellent. And Dr. Moore.
Yeah, I think my the thing I'm most excited about, to be honest, is finally being able to use potentially AI to access big systems that have Epic to do early interception in ovary cancer and get patients recognized months earlier, so we actually have a shot at curing their cancer. I'm pretty excited about that potential, because I think if we get these tumors, they won't be stage 1, but if we get them at low volume and really are aggressive, then we can use these targeted therapies that are being developed to really try and cure more patients, or markedly improve their disease-free survival, so they're getting something for a year or two and then off something for many years, to really improve the length of time people live, but also the length of time people live off therapies. And I think we can do it. And I think the ADCs are just the beginning of the kind of targeting both extracellular and intracellular proteins to really benefit patients. But we have a lot of work to do to figure out the biomarkers and get it right in the front line. So I think in my career, we're going to start making some headway. I'm not that old. I'm getting a little old, but I think we're going to get there. And that's what our patients need. They don't need more things once they're having bowel obstructions and ascites and have a year left. We need stuff moved up front and to do things that help them treat and then come off treatment and live without being continuously under the influence of a drug for as long as possible. That's what I'm excited to do.
Excellent. Well, thank you again, Dr. Moore, Dr. Kazi, and Dr. Lisberg. It's been a very insightful conversation, and we look forward to engaging with each of you in the future. And for our attendees, thank you for listening in. And this session will be made available for those who have registered. All right, take care and enjoy everyone's day. Bye.
Thanks.
Thank you.